Okay, hello again. Um, in the second part of this presentation, we will continue talking about surgical endodontic procedures, but our main focus in this presentation will be the periordicular surgery or the episectomy. Now, it's important to keep in mind that the underlying etiology of periapical disease is microorganisms, and we're mainly talking about bacteria here. Um, and our objective when doing endodontic treatment, whether it's surgical or non surgical, is the same. We want to eliminate and prevent apical periodontitis. If apical periodontitis is already established, we want to do an endodontic treatment to induce healing, or if it's not there, we want to prevent the formation of apical periodontitis. The surgical or and non-surgical techniques have the same aim, but the technique is somehow different. Non-surgical options should be our first choice when treating apical periodontitis. However, when this option is impractical or the non surgical approach is unlikely to improve on previous results, then periapical surgery will be indicated. Now, to make the right decision on whether periapical surgery is the best treatment option or not, the following factors should be taken into consideration. First of all, we have to look at the patient's medical history. If the patient has bleeding disorder, then we should be careful when deciding if surgery is the best treatment option, or if the patient is taking bisphosphonates or undergoing radiotherapy and has a high risk of developing osteonecrosis of the jaw, then all attempts should be made to avoid subjecting the patient to surgical procedures. And the surgical treatment option should be the last resort in this patient and after consulting their physician. We should also look at the aesthetics. If we're doing a surgery on the maxillary anterior teeth, we should look at the patient's lip line level. If the patient has a high lip line, one of the complications or the disadvantages of some flap designs is recession of the gingiva. So if the patient has a high lip line, or if they have multiple crowns on the anterior teeth, there is a risk of recession and exposure of the crown margins. These are things that should be discussed with the patients before attempting the surgery. We should look at the periodontal health of the patient. If there are any pockets associated with the tooth that we need to operate on, or if there's any mobility, we should look at the recession before the surgery. Of course, when doing a periordicular surgery, we need to cut part of the root, so we should keep in mind the crown root ratio before doing the surgery. Also, we should look at the quality of the root canal treatment that has already been done. If there is any chance to improve on it by non-surgical approaches, then we should attempt a non-surgical endodontic treatment before doing the surgery. Financial implications should be discussed with the patient. If, for example, look at this radiograph of a long span bridge replacing two teeth. One, the mesial abutment has a long post. The margins of the restorations are well adapted to the teeth. If, for example, this patient developed signs of apical periodontitis on the mesial abutment, then we should inform the patient that if we're doing a non-surgical approach, we need to dismantle the coronal restoration, which means that they may lose the bridge. We need to remove the post, and there is a risk of root fracture when removing the post. We should do a root canal retreatment, and then afterwards we should reconstruct the coronal restoration, so putting a new post and a new bridge. This, of course, will be very costly to the patient, and in these cases, we should discuss the surgical approach, which means that we only need to reflect a flap and do a resection of the apical part of the root of the mesial abutment. Of course, this will save the patient some money. This is, of course, a more invasive option, but on the financial side, it's less costly. Um, Also, we should look at the restorative status of the tooth. If this tooth is going to be an abutment for a single crown, or is it going to support a fixed bridge, or it is an abutment for a removable bridge. We should look at the functional and occlusal loads that are expected to be put on this tooth. Um, of course, we need to consider the amount or the coronal tooth structure. Is this tooth restorable and we can invest on it, or it would be better if we extract it and replace it with an implant. Now, in conclusion, both surgical and non-surgical endodontic treatments are valid treatment options with the same aim, which is elimination and prevention of apical periodontitis. However, it's the identification of the cause of the disease that's the key for success. Now, surgical treatment is indicated when the less invasive non-surgical approach is impractical or unlikely to improve on previous results. The patient should be involved in the decision-making process. So don't take the decision on your own. Involve the patient in the decision-making process. Explain the pros and cons of each treatment options, the cost implications, the what's expected after the surgery or the non-surgical treatment, and then let the patient decide. Once we've decided that surgery is the best treatment option, the first step is administration of local anesthesia. Now, the injection of a local anesthetic agent which contains a vasoconstrictor has two equally important objectives. First, we want to obtain profound, prolonged anesthesia. Secondly, we want to provide good hemostasis both during and after the surgery. Now, if we fail to achieve this step properly, then we will induce pain and anxiety unnecessarily to the patient during the surgery, and of course, inadequate hemostasis, which will result in poor visibility and compromised treatment. So, good anesthesia is key for successful endodontic surgery. Now, you probably know that the two major groups of local anesthetic agents are esters and amides. Both are able to produce profound anesthesia, but they differ in the manner in which they are metabolized and their potential for allergic reactions. Of course, esters have much higher allergic potential than amides. Therefore, we usually use amides like lidocaine or articaine with vasoconstrictor. Epinephrine is the most effective and most widely used vasoconstrictor agent in dental anesthetics. Now, in addition to the choice of the anesthetic and the vasoconstrictor agents, the site and the technique of injection are important factors as well. Although you may think that block anesthesia will produce profound pain control, especially in the mandibular posterior teeth, block injections are not useful to achieve hemostasis. So even if you give a block anesthesia to control the pain, you need to administer anesthesia by infiltration in the surgical area to produce effective hemostasis. Okay? So it's important to note that whatever technique is used to obtain anesthesia, infiltration in the surgical site is always required to obtain hemostasis. We should give a sufficient amount of anesthesia. And this is determined by the complexity of the procedure and the time expected to perform the surgery. So in most cases, 2 to 3 carpools should be adequate. Now, we should keep the following in mind when designing the surgical access to the diseased tissues. So, after we've administered the anesthetic agent, we should have the following in mind. We should have thorough knowledge of the anatomy of the surgical site. We should know the anatomic structures in relation to each other, including tooth anatomy, frenum muscle attachment, the width of the attached gingiva, the papillary height and width, if there are any bony eminence, or and we should know the crown margins of the teeth before doing our incision. It's also good to have a three-dimensional image of the structure of the soft and hard tissue in the area, and for this purpose we may need a CBCT as part of our pre-surgical assessment, especially in complex periradicular surgery. For example, if we have a large periapical lesion in the posterior area, and we want to evaluate the proximity of the lesion to the adjacent relevant anatomical structures such as the neurovascular bundles or the maxillary sinuses. CBCT will be useful in these cases. And also, we should do our best to reduce the trauma produced by the surgical procedure itself. So, by gentle handling of the soft tissues, avoid forceful retraction of the soft tissues, minimize the amount of bone trimmed from the area. These should reduce the healing time and reduce the morbidity after the procedure. Now, so we've administered the anesthesia, we've done our pre-surgical assessment. Now it's time to gain access to the diseased tissue, and this is done by reflecting a flap. Now, to make the incision, to make the flap, we need a 15C or a microblade. The microblade has a pointed end, and it gives you better control and more in more delicate tissues. For example, when you do a papilla-based flap, which we will talk about in a few minutes, you need this blade because it gives you a precise, neat incision. And you also need a 15C blade, which has a longer, more extending cutting edge. Okay. Now, when it comes to flap designs, we have two major categories. We have a full mucoperiosteal flap, which includes the gingival margins, the dental papillae, and the attached gingiva and the alveolar mucosa. All of these will be included in the flap. Or we can have a limited mucoperiosteal flap, and the aim of these flap designs is to eliminate the need to disrupt the gingival margins, especially those around restorations where recession would be the most noticeable. So in the limited mucoperiosteal flaps, we don't reflect the gingival margins, or we don't reflect the papillae, as we will see later, to reduce chances of recession, gingival recession after the surgery. Now, according to the number and the direction of the vertical releasing incisions and the position of the horizontal incisions, these flaps can be divided into the following. When it comes to the full mucoperiosteal flaps, we can have only a sulcular incision, which will produce a gingival envelope flap design with no vertical relieving incisions. Or we can have a sulcular incision with one vertical releasing incision, and this will produce a triangular flap. Or we can have a sulcular incision with two parallel vertical relieving incisions on both sides of the flap, and this will produce a rectangular flap. Or we can have an intrasulcular incision with two angled vertical relieving incisions, and this will produce a trapezoidal flap. Now, when we talk about limited mucoperiosteal flaps, we can have just one curved submarginal or semilunar flap in the attached gingiva, or we can have a papilla-based flap in which we only reflect the gingival margins and the papillae will be left in place undisrupted. Or we can have a scalloped submarginal flap in which we place our horizontal incision in the attached gingiva, submarginal, so below the gingival margins. Okay? We will talk in more details about each of these flaps later on. Now, regardless of the type of the flap we decide on, these principles should be kept in mind when doing a flap and when we place our incisions. Okay, first one, we should. The aim of the flap is to provide access to the diseased tissue. So, a minimal flap should include one tooth mesial and one tooth distal to the intended tooth. So if, for example, we decide to do a periapical surgery for the maxillary right central incisor, our flap should extend one tooth mesial and one tooth distal to the tooth we're operating on, okay, to provide enough access to the surgical field. Now, the second principle is related to the dental papilla. Dental papillae should be included or excluded in the flap, but not dissected. So we can include the papilla in our flap design, or we can exclude it from the flap, but we should not dissect in the middle of the papilla, because this will lead to loss of the papilla and disruption and distortion of the papilla, especially when we place the suture there. You will end up with loss of the height and width of the papilla, and you will end up with black triangles and compromised aesthetics. The third principle is related to our vertical relieving incisions. The best vertical relieving incision should run parallel to the supraperiosteal blood vessels in the attached gingiva and the submucosa. So the supraperiosteal blood vessels, they run parallel to the long axis of the teeth, and our vertical relieving incision should be parallel to these blood vessels, because otherwise, if we angle our vertical relieving incisions, then we will end up severing and cutting multiple blood vessels, which will lead to bleeding and poor hemostasis and poor visibility during the surgery. So the rectangular flap design is better than the trapezoidal flap design. They used to claim in the past that if you design a flap, the base of the flap should be wider than the coronal part of the flap. This is not valid anymore. If you make your vertical relieving incisions, you will get good access, and at the same time you will disrupt minimal number of blood vessels, and you will have better hemostasis and better visibility to the surgical site. Also, we should not place any incisions across frenum or muscle attachments, because this will affect the healing of muscles will be with scar, and this will affect the mobility of the soft tissues. So your patient will come back telling you that they feel their lips are not moving as they used to do before the surgery, or they have a funny feeling just around the frenum or muscle attachment. So no cuts should be made across a frenum or muscle attachments, and no incisions should be made above bony eminences, especially on the canine region, because this will place unnecessary tension on both sides of the flap and will reduce chances of healing. The incisions should be placed on healthy bone, So we shouldn't place our incision on a bony cavity or on bony fenestration or bony defects, because this will compromise the healing. For proper healing, you need to place your incisions on healthy bone. And can be examined, of course, on radiographs and using CBCT before the surgery as part of your pre-surgical assessment. Now let's discuss the flap designs individually. So the first full mucoperiosteal flap design is the gingival or the envelope flap, which consists of only a circular horizontal incision with no vertical relieving incisions. As you can imagine, this will not be suitable for periapical surgery because you won't get access to the apical part of the root, and if you try to pull the flap forcefully, you may end up tearing the soft tissues and compromise healing. We can use it sometimes to repair cervical defects, for example, cervical perforations of the root or cervical resorption, because we don't need access to the apical part of the root. And this is especially important in the palatal surface, or in the palatal, if you're doing a surgery in the palate, to avoid the vertical relieving incision and to avoid damaging the blood vessels that run in the palate, the major blood vessels, and to avoid bleeding. So we may just need to do a circular horizontal incision with no vertical relieving incisions. The advantage of this flap design is it's modifiable. So if you think that you're not gaining enough access, you can just add 1 or 2 vertical relieving incisions and convert it into triangular or a rectangular flap. So it's modifiable. The disadvantage of this flap, it provides limited surgical access, especially to the apical area of the root. And as with any flap design that includes sulcular incision, it will produce gingival recession after the surgery. In this case, for example, this patient came with incidental finding. On the periapical radiograph, we found a resorptive defect in the cervical part, in the palatal area of the root of the maxillary left central incisor. We reflected an envelope flap on the palate, and we repaired this area with MTA. The second type of full mucoperiosteal flaps is the triangular flap, which consists of a sulcular incision with 1 vertical relieving incision, and usually it is placed on the mesial tooth, okay, of the mesial to the tooth we're working on. This flap is easy to reposition and suture. It provides excellent wound healing after the surgery. We do minimal disruption of the blood vessels because the vertical releasing incision runs parallel to the supraperiosteal blood vessels. It provides good surgical access when compared to envelope flap, and it is also modifiable. So if we think that we're not getting enough access to the diseased area, we can place another vertical relieving incision and convert it to a rectangular flap. Disadvantage of this flap, it causes gingival recession because it has a circular horizontal incision. Now, the last 2 types of full mucoperiosteal flaps are the rectangular and the trapezoidal flap designs. These consist of circular circular incision and 2 vertical relieving incisions, and according to the angles of these vertical relieving incisions, we can classify these flaps into rectangular or trapezoidal. If they were parallel to each other, then this is a rectangular flap. If they were angled to each other, then this is a trapezoidal flap. We know, or we've said before, that a rectangular flap design is better than the trapezoidal because it disrupts less number of blood vessels and gives you better hemostasis and better visibility during the surgery. These flap designs, they provide the best surgical access and they provide excellent wound healing. Some disadvantages of these flaps, of course, they will cause gingival recession because they include a circular incision, and also sometimes because the flap will be movable, uh, it is sometimes difficult to reposition and suture these flaps because the flap is mobile from both sides. Now let's move into the limited mucoperiosteal flaps. The first category is the curved submarginal or the semilunar flap design, which includes a curved incision, horizontal incision in the attached gingiva with no vertical relieving incisions. They provide poor access and they cause scarring, and because the incision is perpendicular to the supraperiosteal blood vessels, then it will induce bleeding and it will cut multiple blood vessels, causing poor hemostasis during the surgery and compromised visibility. There is a risk that we can place the incision on the bony defect, which will also compromise the healing. And this flap is not modifiable, and you cannot extend it once you've made this incision. It's done. It's not modifiable. Now, the other category of the limited mucoperiosteal flaps is a flap design called the papilla-based incision or the papilla-based flap design suggested by Peter Vilvert. Because we've said with the full mucoperiosteal flaps, there is always a risk of gingival recession, especially in the papilla area. Peter Vilvert suggested that we can spare the dental papillae and leave them in situ and place our incision at the base of these papillae. So this flap design consists of a shallow incision at the base of the papilla. We place this incision around 2 to 3 millimeters deep, and then we tilt the blade and direct it towards the crystal bone, and we place our second incision. Then we move around the gingival margins in the sulcus of the tooth. Of course, for this flap, you need a micro blade. The 15C will be difficult to use. Now, when you reflect this flap, as you can see, the papillae are left inside, in situ, and only the base of the papillae and the gingival margins are reflected. This will provide predictable recession-free healing in the dental papilla area and will not produce black triangles at the end of the surgery. You can imagine that this flap design is technically challenging, and this is the only disadvantage for it. Now, the last subcategory of the limited mucoperiosteal flaps is the scalloped submarginal or Oshinbein-Lobke flap design. Or some people pronounce it as Oxenbein flap design. So in this flap, we place our horizontal incision in the attached gingiva, in the subgingival margin area. And this horizontal incision will be scalloped to reduce scarring. So if we place our horizontal incision as a horizontal line, okay, and we don't follow the contours of the teeth, then this will provide or will produce a visible or obvious scar, while if we do it in a scalloped manner, this will produce a minimal scar and it will not be that much obvious. And then we place two vertical relieving incisions. The aim of this flap design is to spare and preserve the dental papillae and the gingival margins to reduce recession, especially in the anterior maxillary anterior teeth, and especially if the patient has crowns on these teeth, and we don't want to get any recession, and we don't want the margins of the crowns to be exposed after the surgery. Um, but, but in order to be able to do this flap design, we should have at least 3 millimeters of attached gingiva. So the amount of attached gingiva varies between patients. So this patient has almost like over 10 millimeters of attached gingiva, while on the other hand, this patient has only 1 millimeter of attached gingiva, and this patient will not be suitable for this flap design. So you need a broad band of attached gingiva, at least 3 millimeters, in order to do this flap design. This will produce recession-free healing after the surgery. Now, the disadvantages of this flap, it will provide limited access in comparison with the full mucoperiosteal flap, and it, of course, you will end up with a scarring, but it won't be much visible if you do a scalloped horizontal incision, and of course there will be hemorrhage in the surgical area because the horizontal incision will be placed perpendicular to the supraperiosteal blood vessels. This is my preferred, I prefer this flap design in most of the surgeries I do. Now, after we've made and we've placed our incisions, then we have to reflect the soft tissues, and for this purpose we need a periosteal elevator, a sharp one, in order to avoid force and avoid stress on the flap and avoid tearing the soft tissues. Then we need a retractor to retract the soft tissue flap, and the retractor should be placed on sound bone. Now, in many of the cases, and you probably know this from before, that when you have a radiolucency on periapical radiographs, this means that at least one of the cortical plates, the buccal or the palatal, is already perforated by the periapical lesion, okay? In these cases, you will have the bony cavity and the soft tissue obvious in the area, and you don't need to trim more bone to gain access to the apex of the tooth. But sometimes the apex of the tooth will be covered with bone, and in these cases we need to do osteotomy. And osteotomy is usually done by a sharp round burr on a high-speed handpiece. We should use a large amount of sterile saline irrigation to avoid irreversible damage and necrosis and overheating of the bone. And the burr should be used in a light brushing motion to avoid heat generation, okay? And this is the handpiece that we should use. This handpiece exhausts the air at the base rather than from the cutting end, and this will help us avoid inducing or forcing the air into the surgical site and causing air embolism, okay? So the high-speed handpiece that we should use to do our osteotomy should exhaust the air from the base and not from the cutting end, okay? And we use a sharp round burr to do our osteotomy. Now, after we remove the bone, then we will see the soft tissue, the lesion, the granulation tissue or the cyst around the root apex, and we need to remove it or to curette it, okay? And for this, we need a curette, And the objectives of curettage is to provide access and visibility to the root apex. Okay. And also we want to remove the inflamed tissue and reduce hemorrhage, because granulation tissue will be highly vascularized and it will bleed profusely if disrupted. So we need to remove this inflamed tissue. And also we need to take this soft tissue for biopsy specimen and for histologic examination, okay, and to make to have an idea about the nature of the periapical lesion. Now, the tissue should be peeled out carefully, ideally in one piece, using a suitable curette. And then we have to make sure that we end up with a clean bony crypt or bone cavity. We should keep this, the soft tissue or the diseased periapical tissues in we store it in formalin, and then we send it for histologic examination. We fill up the biopsy form to the lab. We give details about the patient, patient's age, symptoms, the date on which the surgery was done. We give some clinical presentation about the case, and we give some symptoms of the patient. We write it down, and then we send it to the lab. The results should come back with the histologic diagnosis. Okay. Now, histologic studies have shown that most of these periapical lesions are granulomas, so inflammation in the periapical tissues, granulation tissue. Okay. In 12% of the cases, these were abscesses, and in almost 15% of the cases, they were cysts. Okay, so we won't be able to tell if the periapical lesion is a cyst or an abscess or a granuloma from radiographs. Okay, we only can tell this by histologic examination. Now, once we've removed the diseased soft tissue in the periapical area, we should resect the root end. And the purpose for root end resection is to remove the apical part of the root, which will contain most of the ramification and the accessory canals that are difficult to clean with non-surgical approaches. So if you cut 3 millimeters from the root end, this should eliminate over 98% of the apical ramifications that are difficult to clean, and they may be responsible for the failure of the non-surgical treatment. Okay, so we cut 3 millimeters from the root apex. Now, to do this, we need a tapered Fisher burr on a high-speed hand piece with copious irrigation with saline. Our resection angle, the resection angle should be perpendicular to the long axis of the tooth with no bevel, and we will know the reason for this later on. After we resect the root end, we use a micro mirror to examine the root end, and we use methylene blue dye to check if there are any cracks or isthmuses or accessory canals visible at the root surface, and we need light and magnification, of course. After we cut the root end, we have to prepare 3 millimeters of the root end. Okay, and the aim of root end preparation is to remove the intracanal root canal or intracanal filling material, the gutta percha and the sealer, and to remove irritants to debride the root end, and we want to create a cavity to place the root end filling in. Okay? The apical preparation is now done by suitable ultrasonic tips that have different angles to enhance the accessibility to the root end. We prepare a class 1 cavity that is at least 3 millimeter deep, okay, with parallel walls. Previously, the root end was prepared with burrs and handpieces, and for this reason, because the head of the handpiece is large, and to gain access to the root end, we had to do a bevel when we resect the root end. So this is not needed anymore, because we have now ultrasonic tips that have different angles to allow accessibility to different roots for all of the teeth. And these ultrasonic tips has helped us to prepare isthmuses as well, which was very difficult to prepare previously when we used to use hand pieces instead of ultrasonics. So if you compare the root end preparation using ultrasonic tips versus preparation of the root end using burrs, ultrasonic tips will produce a smaller apical preparation, so no need to cut excessive amounts of dentine. Ultrasonic tips will allow us or will give us easier preparation to isthmuses. Also, we are able to follow the direction of the canal in a better way, so we don't need to cut dentine from everywhere. Only in the canal area we prepare the canal, and we don't deviate from the long axis of the canal. We are able to clean the canal surfaces in a better way, and the ultrasonic tips produce less fatigue when compared to using the heavy burrs, okay, the heavy hand pieces. So the ultrasonic tips are lighter and they produce less fatigue when compared to using hand pieces and burrs. So to give you an insight about the traditional and the more modern surgical techniques, this handpiece was used previously to resect the root end. As you can see, it has a large head which will compromise the accessibility and the visibility to the surgical site. These micro handpieces are used now instead, which will give us better access to resect the root end, and then we can easily prepare the root end. So no need for a bevel. The bevels were prepared previously to allow us to see the root end, okay? But now, because we have angled suitable ultrasonic tips, there's no need for a bevel. Now, why do we have to resect the root end perpendicular to the long axis of the tooth, and why it is preferred when compared to angled resection? Because when you resect the root end perpendicular to the long axis of the tooth, the number of the dentinal tubules exposed to the periodontium will be less, okay? And you know that even if we do our best to clean the root end, the root canal, regardless of how thorough we were, we won't sterile the root canal, okay? So there will be remaining bacteria and irritants in the canal. Now, if we prepare the root end or resect it in a perpendicular way, the number of dentinal tubules, which are pathways or avenues of communication between the root canal and the surrounding periodontium, will be less, okay? But the number of the dentinal tubules that are exposed if we do an angled root resection with a bevel will be much more, which will lead to leakage of the irritants from the root canal into the periodontium and will compromise healing. So from a biologic perspective, the most appropriate angle of root end resection is perpendicular to the long axis of the tooth, and this is needed because the probability of irritants from within the root canal system that will gain access to the healing tissue will increase if we increase the angle of resection, okay? Also, if we resect the root end in a perpendicular way, the root end preparation cavity, the class 1 cavity, will be uniform, so we can place the root end filling material in a suitable depth in all uh, in the cavity, in the class 1 cavity. However, if your cavity, if your root end resection angle was not perpendicular, then the cavity depth will not be the same on all areas. So the root end filling will, the amount of root end filling that is placed here will be less than the amount placed here, which will lead to probably dislodgement and stresses on the root surface. So it's always better to resect the root end perpendicular to the long axis of the tooth. Bevels are not needed anymore. Bevels were prepared previously because we didn't have the ultrasonic tips to prepare the root ends, and therefore we used to prepare bevels to enhance the accessibility to the root end, but this is not needed anymore. Now the next step will be root end filling. The aim of the root end filling, of placing a root end filling material, is to seal any pathway from the root canal to the periradicular tissue. Now, these are the desirable properties of the root end filling material. It should seal well. It should be biocompatible, so it won't cause any irritation to the periapical tissues. It should be bioactive to provide a double seal. And when we say a double seal, we mean a seal that consists of a physical barrier provided by the root end filling. Okay, so physically there is a seal by the root end filling material, as well as a biologic seal formed by regeneration of the periodontal tissues and the bone around the resected root surface. And this is the ideal outcome. And this has been shown to be achievable by using calcium silicate based root end filling materials such as MTA. You can see this is the MTA at the root end, and the periapical tissues has regenerated, so we have periodontal ligament crossing the MTA, and then the bone has also regenerated. Root end filling material should also be non-resorbable, so it should not be lost with time. It should not be affected by moisture. You know that the surgical field, there will be blood, so the root end filling material should not be affected by blood and moisture, and should have good handling properties and should be easily inserted into the root end. Amalgam was used traditionally as a root end filling material, but it should not be longer. It's no longer used as a root end filling material. Also, we have zinc oxide eugenol based root end filling materials such as IRM or Super EBA. However, MTA consistently results in regeneration of periapical tissues, including periodontal ligament and cementum. There are a variety of root end filling materials to choose from. I wanted to share with you the MTA, or to show you the MTA and the biodentine. Both are calcium silicate based materials. Biodentine have probably better handling properties and a shorter setting time than MTA. The original MTA had difficult handling properties, and it used to have a long sitting time, but newer generations of MTA have less sitting time of 15 minutes or so. It comes as a powder and liquid. You mix them together, and then you use a special carrier system, the MAP system or the microapical placement system. It's like an amalgam carrier, but it has a long flexible tip, and it comes with different angles, different diameters depending on which tooth you're working on. Biodentine comes as capsules which contain the powder and ampules that contain the liquid. You add the liquid to the powder, and then you mix the capsules in the amalgamator, and then you place the material in the MAP system, and then you inject it into the root end. After we place the root end filling material, we condense it with micro pluggers. Okay, so we make sure that the material is well condensed into the cavity. Then we place or reposition the flap, and we should place some pressure using our fingers on a moist gauze on the flap, and this is done to allow expression of hemorrhage and blood from under the flap. It improves the initial adaptation, and it gives us it makes suturing easier, and reduces post-operative swelling and bleeding. Okay, so place some pressure on the flap after repositioning it using a gauze. So put your fingers on this gauze and press the flap into its place for 5 minutes or so, and then you can start suturing. The best suture is a non-resorbable synthetic monofilament suture. These will reduce chances of wicking of bacteria into the surgical site, and therefore provide better healing when you compare it to silk sutures, for example. Sutures should be removed after 2 days or a maximum of 4 days. Sutures should not be left for a long time in place. This will lead to wicking of bacteria and will delay healing. Now, we should give the patient verbal and written post-operative instructions after the surgery. We, of course, as with any surgical procedure, you should inform the patient that they should expect some pain, swelling, bruising, infection, or bleeding, and these are usually manageable. So for pain, we prescribe anti-inflammatory medications, or sometimes after suturing the flap, we can give a long-acting anesthetic such as bupivacaine in the area. This will reduce post-operative pain. We tell the patient that they may see some blood oozing from the surgical site, and this is normal. You can give them gauze and ask them to place some pressure on the area to stop the bleeding. Tell the patient that some swelling is normal after the surgery. To reduce the swelling, they can use cold compresses on the area on and off for up to 6 hours after the surgery. Now, if the patient is smoker, advise them to stop smoking for 3 days after the surgery, because smoking will reduce the blood supply to the flap area and will compromise healing. We should give the patient verbal and written post-operative instructions, and these should include chlorhexidine mouthwash should be used to keep the surgical site clean until the sutures are removed. Also, they should maintain a proper diet, and they should have fluid intake. These are essential after surgery. Prescribe some painkillers. Some antibiotics are needed only if a patient's medical history requires so. So antibiotics are not usually prescribed after surgery. Keep or make an appointment for the patient to remove the stitches after 4 days, for example. Now, you can ask the patient, give them the contacts of the surgery, and ask them to call you if they have any concerns or any questions. Now, what about the outcome of endodontic surgery? Both root canal retreatment, so the orthograde approach, and the periapical surgeries, they are valid and highly predictable treatment options for managing endodontic failures. Studies have shown that endodontic surgery will give you a higher short-term success. So if you have a periapical lesion, okay, in 2 cases, one case you treated surgically and the other one you treated non-surgically. On the short term, the surgical treatment will give you better or higher success. Why? That's because you're removing the cause of the surgery, the cause of the disease. So we remove the disease tissue, we remove the periapical irritants, or the disease tissue that has caused the patient's symptoms. Uh, but with the non-surgical approach, we're waiting for the normal body healing response. Okay, so it will take some time for the non-surgical approach for the tissues to heal. However, on the long term, both the surgical and non-surgical options will give you the better, the good or the same healing rate. Okay, so on the short term, surgery will give higher success. But if you look at, for example, after 4 years, you will find that both surgery and the non-surgical treatment will offer the same long-term healing rate. Okay. Now, the use of microsurgical techniques has significantly improved the success of the surgery when you compare it to traditional techniques. So, when using the microsurgical techniques, the success rate is almost 94%, while the traditional approaches, the success rate of the surgery was 59%. What do we mean by the microsurgical and the traditional techniques? Using the traditional techniques, we used to do a large osteotomy site to allow our large instruments to get access for these large instruments to the surgical area. We used to do a large bevel to increase visibility of the root end surface. We didn't have light and magnification to inspect the root surface, so probably we may end up with cracks or uncleaned isthmuses, and we won't know about these because we don't have magnification or light. The root end preparation was very difficultly done using burrs and handpieces. So the root end filling used to be amalgam. We used to use silk sutures that will lead to wicking of bacteria and compromise healing. Suture removal was done around a week after the surgery, which also increases the chance of wicking of bacteria and reduces healing. So the success rate was very low. While with the microsurgical approaches, our instruments are smaller, so our osteotomy size was smaller. We don't need to do bevels anymore because we're using ultrasonic tips. We are always able to inspect the root end with the use of microscope and magnification and light. We are able to prepare isthmuses using suitable ultrasonic tips. We use calcium silicate materials such as MTA, which are biocompatible and bioactive. Our suture is monofilament, synthetic, and it won't lead to wicking of bacteria, and the and they are removed 4 days after the surgery, which will improve the healing. And that's why we ended up with much higher success rate of 94%. Okay. Now, you may ask, what are the factors that affect the prognosis or the success of endodontic surgery? And here is the answer to your question. First of all, the size of the periapical lesion. Okay, so if we have a small periapical radiolucency that is 5 millimeters or less in diameter, we will have higher success rate than a large lesion that is larger than 5 millimeters, okay, in diameter. If the periapical lesion involves one cortical plate, then the chance of success is better than if the periapical lesion involves both cortical plates, the buccal and the palatal. Okay. Now, if you're doing the surgery for the first time, then the success rate is much higher than if you're doing a resurgery or another surgery. The success rate will drop significantly. If you're using the microsurgical techniques and you're using magnification and you're not doing a bevel and you're using ultrasonic tips to prepare the root end, you're cleaning isthmuses, then your success rate will be much higher. If you're using MTA or other calcium silicate based materials, then your success rate is high, okay, when you compare it to amalgam, for example. And also, very important factor, the quality of your coronal restoration. It's very important. The quality of the coronal restoration is important to achieve success in both surgical and non-surgical endodontic treatment. Now, with the follow-up protocol, you should take an immediate radiograph following the surgery or when the patient comes back for the suture removal, okay? And you use this as a baseline record for the patient to compare it with future films to assess healing. Now, surgical endodontics should be assessed after 1 year and subsequently as required. So you bring the patient back after 1 year, you take another radiograph. If the lesion has disappeared, then this is a good sign, your treatment is successful. If the lesion is becoming smaller but it's still there, then you bring the patient on the following year and take another radiograph and assess the size of the lesion. Ideally, you want a cementum and periodontal ligament should regenerate on the radiograph over the resected root apex. When you take the radiograph after 1 year of the surgery, if you have to look at the cementum and the periordicular tissues. Ideally, you should see the cementum and the periodontal ligament regenerating over the resected root apex. Although sometimes the healing will not be by regeneration, it will be by scar formation or a fibrous tissue formation. We shouldn't be confused and think that this is a sign of a failure. Okay, so if the patient's symptoms has disappeared, but we are seeing a radiolucent area around the apex, then we should make sure that we should follow up the patient later on and make sure that this is not a lesion. It can be a scar tissue only. Okay. So our ideal outcome, we want to see absence of pain, no swelling, no other symptoms. We should see satisfactory healing of soft tissues, no sinus tracts or any signs or symptoms of infection or inflammation, no loss of function, and radiological evidence of repair of the periapical tissues, including reformation of periodontal ligament space and cementum. And that's it for our presentation. Thank you for listening.